Imagine you're trying to recover from an injury, right? And you're already dealing with the whole workers' comp system, which
Mhm.
is, let's face it, pretty complex. Then suddenly there's someone new assigned to help you. But what if that help comes with some unspoken agendas or maybe some unexpected pressures? That's kind of the tricky dynamic we're exploring today.
Yeah, exactly. Our deep dive today is focused on the Office of Workers' Compensation Programs, OWCP. And specifically, we're looking at the role of OWCP case managers. You might hear them called nurse case managers or field nurses. They work on federal workers' compensation claims, FECA claims. And like you said, they're introduced as these intermediaries, supposedly there to help you recover and get back to work.
But, and this is the big but, right? Their involvement can, well, it can create some real tension, raises questions about who's really in control. So our mission today is to equip you, whether you're the injured worker or maybe you're the doctor treating them, with the knowledge you need. We want you to really understand their role, feel confident in those interactions, and crucially, keep control over your own medical decisions. We're going to unpack some surprising facts, I think, and definitely give you some practical strategies. You'll feel much more informed and hopefully empowered. Okay, let's pull back the curtain then. Who exactly are these people, these field nurses or nurse case managers?
Well, fundamentally, they're typically registered nurses.
Mhm.
RNs, OWCP contracts with them to provide these disability case management services. Usually when they first get assigned, it's for an initial 120-day period, though that can get extended, especially if it's a new injury claim.
Okay, 120 days initially. And what are they actually doing in that time? What does the job really entail beyond just, helping?
Right, so a pretty broad scope, honestly. Their duties cover a lot of ground. One big piece is facilitating medical care. So they'll assess the injury, work to make sure you're getting timely medical attention, rehab, that sort of thing.
Right.
They might help schedule appointments or find specialists. And here's something interesting.
Yeah.
OWCP nurses actually have limited authority to authorize certain minor non-invasive tests. Think like an MRI. They can sometimes okay that without separate OWCP approval just to speed up diagnosis and recovery.
Really? They can greenlight an MRI on their own. That seems surprising.
Limited authority, yeah. For minor non-invasive things, the idea is efficiency. But, anything major or invasive procedures, that still needs formal approval from the claims examiner, the CE.
Okay, that distinction is important. So they can grease the wheels a bit for smaller stuff. What else?
A huge part is communication and coordination. They're basically the liaison, connecting the injured worker, that's your treating physician, your employing agency, and the OWCP claims examiner. The stated goal is, and I'm quoting here, use all available tools to facilitate medical recovery and a successful return to work. It's meant to be a team approach, so they're collecting medical reports from doctors and also relaying concerns back to the doctor or to you, maybe from OWCP or your employer. And then there's the return to work planning. This is really central to their job. They're communicating expectations about returning to work, asking your doctor about restrictions, letting you know if there are light-duty jobs available. Often they'll give your doctor a detailed description of your regular job duties. Why? To get the doctor's opinion on releasing you back to full duty.
So definitely focused on getting people back on the job. I guess that means they're also keeping a close eye on how you're doing medically.
Oh, absolutely. That's monitoring and reporting. They track your medical progress very closely. They often attend key medical appointments in person, especially if it looks like there might be a significant change coming up. Like maybe the doctor's about to say you can do some work or that you've reached maximum medical improvement, MMI. They get updated treatment plans, work status reports from the doctor regularly, and after every significant contact, they write up these reports for the claims examiner, documenting your condition, your progress. It all goes into your claim file.
Wow. Okay, so they're documenting constantly. Anything else in their toolkit?
Yeah. Finally, they also help with facilitating OWCP processes, sort of navigating the bureaucracy.
Mhm.
They might assist your doctor's office with OWCP paperwork, like the CA20 or OWCP5 forms, making sure stuff gets submitted on time. And they can help get prior authorizations for tests or treatments, linking back to that first point. Now, here's a really crucial insight. It gets missed a lot. While they are super active, they do not have decision-making authority on the claim itself. They can't approve your claim. They can't deny it. They can't approve or deny specific benefits. That power, legally, stays with the OWCP claims examiner. The nurse's role is officially advisory and facilitative, and they're supposed to be non-adversarial and unbiased.
Advisory and facilitative. Okay, that sounds good on paper. But this is where it gets really interesting, right? How do these interactions actually feel? When the nurse starts talking to you, the injured worker, and to your doctor, this is where those boundary questions pop up. Exactly. Let's start with their communication with physicians. Yes, an OWCP nurse case manager is allowed to talk directly with your treating doctor. In person, on the phone. Like you said, they often attend appointments with you. They can discuss treatment plans, your work capacity, all that. However, and this is the absolute key takeaway for doctors and patients, the treating doctor has the final say, always, on all medical decisions.
Always.
Always. A nurse case manager cannot direct medical care. They can't change it on their own say-so. Sure, they can ask questions, they can make suggestions, but they cannot mandate that a doctor change treatment. If a nurse seems to be pushing a doctor, maybe to release you back to work early or to limit care somehow, the physician is not obligated to follow that, not at all. The doctor's decisions have to be based on their medical judgment and what's best for you, the patient.
That's huge. The doctor's word is final on medical care. But, in reality, does that pressure from the nurse ever work or cause issues? It can certainly create friction. I mean, doctors might feel pressured, even if they know they don't have to comply. The nurse might frame things in a way that emphasizes return to work, suggest alternatives. For the doctor, the best defense is clear documentation and sticking to their clinical judgment. Now, let's talk about the interaction with claimants with you. From your viewpoint, the nurse can seem, very involved. They'll contact you pretty quickly after they're assigned. You explain their role. And yeah, they might come with you to doctor visits. You're generally expected to cooperate with them.
Expected to co-op. Okay.
But here's that crucial insight again, and I'll use that blunt quote from a legal expert because it captures the potential dynamic. The OWCP field nurse is not on your side and may just be looking for information to influence OWCP's decision to take you off compensation. Harsh, maybe, but it highlights a key point. While the nurse is a healthcare professional, their ultimate client is OWCP.
Right, not you.
Not you personally, no. Their reports, their communications, they go straight to the claims examiner. And they can be used to make decisions about whether your benefits continue. Some injured workers have reported feeling like nurses might try to bully you or ingratiate themselves to find incriminating information. That's a reported perception anyway.
Okay, that's a pretty stark warning. So, knowing that their loyalty ultimately lies with OWCP, what about boundaries? Especially in those doctor's appointments. What can you actually control?
You absolutely have a right to medical privacy during the actual physical examination and treatment. If having the nurse in the room during the exam or during sensitive parts of the conversation with your doctor makes you uncomfortable, you can politely ask them to step out. A really common and often effective compromise is this. Let the nurse join the appointment just for the last few minutes. So the doctor can summarize the work status, the treatment plan, updates, whatever, with the nurse present, but after you've had your private discussion.
That sounds like a reasonable approach. Like, okay, you can come in for the wrap-up.
Exactly. You could say something like, I prefer to speak with the doctor one-on-one first, but I'm okay with you coming in at the end so we're all on the same page about the plan. And remember, similarly, your physician isn't obligated to drop everything to take the nurse's call immediately or change treatment just because the nurse suggested something.
So the bottom line for your control, it sounds like, yes, the nurse might help cut through some red tape, which is good, but you always have to remember their role inherently aligns with OWCP's goal of moving the case along potentially towards closure. Knowing that upfront helps you and your doctor keep the focus where it should be on your medical needs. Okay, let's talk about the typical timeline. Knowing the usual flow of how OWCP case managers get involved can probably reduce some anxiety, right? Helps you know what to expect and maybe set boundaries early. What does this journey usually look like?
Yeah, it often follows a pattern. It can actually start very early on, sometimes with what's called an early nurse assignment or a COP nurse. This happens mainly with traumatic injuries. If you're not back at work within about a week, OWCP might assign this initial nurse during your continuation of pay period. This COP nurse usually works just telephonically over the phone for that first 45-day COP window. Their job is really to triage the case, flag the serious ones, and then their involvement usually ends after those 45 days.
Okay, so that's a very specific short-term role. What happens after that if you're still out of work?
Right, so if OWCP accepts your claim and you're still not back to work, that's when a field nurse or FN typically gets assigned. You can expect them to contact you and your doctor pretty early in that process. Field nurses, unlike the COP nurses, usually work in person. They're based in your local area. They'll often attend most of your follow-up doctor appointments, maybe monthly, maybe bi-monthly, and they'll check in by phone too. Remember that initial assignment we mentioned? Usually for 120 days. And they're writing those detailed reports for the claims examiner periodically.
And if things are moving slower, if recovery takes longer than 120 days.
That's when you get into case manager extensions or transitions. If you're not back to full duty after 120 days, yeah, the field nurse assignment can definitely be extended. OWCP sees this nurse intervention as part of what they call quality case management, basically trying to keep cases from just sitting there or languishing.
Yeah.
Now, if your medical recovery kind of plateaus and the main issue becomes finding a suitable job you can do, the focus might shift. A rehabilitation counselor might take over the lead role then. Nurse services are actually considered a component of those broader vocational rehab efforts.
Okay, so the type of support might change depending on where you are in the recovery process. What about interactions with your actual job, your employer?
Good question. The nurse also has interactions with the employing agency. They'll talk to whoever handles workers' comp or HR at your agency. They discuss light-duty job possibilities, and they relay information about those potential jobs back to your doctor and to you. Here's an important point. If your agency happens to have its own internal nurse program, OWCP's nurse takes precedence. Or WCP's nurse will supersede the agency's nurse to ensure there's just one coordinated plan. Avoids confusion.
Right, prevents conflicting advice. Makes sense. So when does this all finally end? When does the nurse step out of the picture?
Ideally, the ending of case management happens when you've either successfully returned to work or you've reached maximum medical improvement, MMI. OWCP doesn't keep nurses on cases forever. Generally, if about a year has passed and you haven't returned to work, OWCP usually shifts gears. They'll likely consider formal vocational rehabilitation or other measures then, moving away from the nurse's direct medical management focus. But throughout this whole life cycle, you should expect frequent communication. That's the norm. Part of the nurse's job is verifying you're complying with treatment and reporting if you're not. On the flip side, though, a really good case manager can be helpful. They can help your doctor with some of the paperwork, help get authorizations faster. That can prevent treatment delays. OWCP itself sees this as, quote, one of the best ways to improve timely communication between everyone involved, doctors, workers, and the claims examiners.
Okay, this leads us to a really big question, one I suspect is on a lot of people's minds. What's really driving these case managers? What are their incentives? Are they truly impartial facilitators, or is there something else going on underneath?
It's a fair question. So OWCP case managers, remember, they're private contractors. They get paid by the Department of Labor using money from the Employees' Compensation Fund. That fund ultimately gets charged back to your specific employing agency. How are they paid? Typically, it's hourly or maybe per task completed. There's no public information suggesting they get direct financial bonuses for closing cases quickly or anything like that.
No direct bonus per case closed, okay?
However, their continued assignment and, getting future referrals, that likely depends on their performance. And how is performance measured in this context? Well, it's measured by how well they meet OWCP's goals. And what are those goals? Facilitating medical recovery, yes, but also helping reduce the duration of disability. OWCP's program is explicitly designed to, quote, shorten the length of disability from work through this kind of active intervention.
Yeah, okay. So even without a direct bonus, there's a clear implicit incentive there, isn't there?
Exactly. There's an implicit incentive to encourage your return to work as soon as it's deemed medically reasonable. Why? Because the faster a case is resolved, the more successful that nurse is likely seen in OWCP's eyes,
Yeah.
which could mean more work for them down the line.
Right. Success equals efficiency and case closure.
Pretty much. Now, ethical guidelines, OWCP's own policies, they all demand objectivity. They talk about a safe and timely return to work. But claimants often perceive that the nurse case managers are primarily there to save money by limiting medical care, limiting time off work. You hear this sentiment a lot. Maybe sometimes more in state workers' comp, but it rings true for OWCP too. The case manager inherently has to balance your needs as the injured worker with OWCP's very real interest in controlling costs and resolving claims efficiently.
So putting it all together, from your perspective, as the injured worker, it seems wise to just assume the case manager is motivated to wrap up your case efficiently. That doesn't automatically mean they'll act unethically or deny needed care. Many are genuinely helpful, but still, recognizing that their role aligns with cost savings and quick resolution helps you, well, interpret their suggestions with a healthy dose of caution, maybe.
I think that's a fair and practical way to look at it, yes. appropriate caution.
Okay, so if they're acting as agents of OWCP and there are these underlying incentives, what are the actual rules? What's the official rule book they have to follow? This seems really critical for understanding your leverage and knowing your rights if you think they're stepping out of line.
Absolutely. They don't operate in a vacuum. There's a pretty comprehensive framework. First, you have the statutory authority, the actual FECA law. Federal law authorizes OWCP to provide medical services, and that includes nursing care. Now, here's a critical legal classification. OWCP considers nurse intervention part of vocational rehabilitation services when it comes to enforcing compliance.
Vocational rehab, even the medical part, that seems counterintuitive.
It does, but that's the legal hook they use. It means OWCP can legitimately assign a nurse and, importantly, expect your cooperation under the vocational rehab rules. Then you have the federal regulations, specifically 20 CFR Part 10. These Department of Labor rules explicitly mention field nurses. Section 10.310 says OWCP may also utilize the services of a field nurse to facilitate and coordinate medical care. But here's the kicker. Sections 10.518 and 10.519, they detail what happens if you refuse to cooperate with vocational rehab efforts. And Section 10.518 specifically states that rehab services include meetings with an OWCP nurse.
Ah, okay. So the regulations directly link nurse meetings to mandatory rehab cooperation.
Precisely. And Section 10.519 says if you fail to participate without good cause, OWCP can reduce your compensation, potentially down to zero. That's why you often get those warnings, cooperate with the nurse or risk losing your benefits. It's grounded in these regulations. The Department of Army even has a Q&A stating this flat out.
So the cooperation isn't really optional from a practical standpoint.
From a practical standpoint, no. Now, there is an important nuance. Some advocates argue the nurse program should be seen as voluntary because it's not, explicitly spelled out word for word as mandatory in the FECA statute itself. But OWCP's official policy, and frankly years of case decisions from the Employees' Compensation Appeals Board, ECAMI, they all support enforcing cooperation. So the safest path for claimants: formally cooperate, show up, talk to them, but do it while still firmly asserting your rights, setting boundaries like we discussed. Beyond the law and regulations, there's the OWCP Procedure Manual and the Field Nurse Handbook. These are OWCP's internal guides. They stress things like nurses needing to be unbiased, maintaining confidentiality, and they constantly reiterate that the claims examiner, the CE, is the ultimate decision maker. These manuals also make it crystal clear that a nurse working for your employing agency has no authority to attend your doctor appointments or direct your care. That's strictly forbidden for agency nurses. Only the OWCP-assigned nurse can do that.
That's a really key distinction, especially if your agency tries to send their own person. Good to know. What about the OWCP nurse's actual scope of authority? What are the hard limits?
By rule, their authority is limited to coordination and communication. Like we said, maybe authorize a minor, non-invasive test. But they cannot authorize major surgery, they cannot make payment decisions, and they absolutely cannot force you to have any specific treatment. Everything they do is subject to oversight and accountability by OWCP staff. Each OWCP district office has a staff nurse and SN who supervises the contract field nurses. They review performance, approve bills. There's also oversight at the national office level. And finally, case law precedents from the ECP have shaped this too. For instance, ECP has upheld reducing benefits to zero for refusing to cooperate with a field nurse, treating it like refusing vocational rehab. But ECV also says OWCP has to clearly warn you about those consequences first. And critically, ECAB has consistently ruled that a nurse's opinion cannot be used as medical evidence to terminate benefits if it contradicts your treating physician's opinion. OWCP would need an independent medical exam, a second opinion from another qualified doctor, to do that.
Okay, so pulling that all together, OWCP case managers have rules, they have oversight, there are legal safeguards. But it really sounds like the power comes from you knowing these rules, too. That's how you make sure the case manager stays in their lane, so to speak.
That's exactly right. Knowledge is your best tool here.
All right, this is the really practical part, the playbook. How do you, the injured worker, empower yourself? How do you protect your rights when you're dealing with an OWCP case manager, trying to walk that line between cooperation and control?
Okay, strategy number one. Stay calm and civil, but be cautious. Look, it's usually in your best interest to appear cooperative. Outright refusal. That can backfire badly and jeopardize your benefits, as we just discussed. So, greet them politely, answer reasonable questions, but internally, maintain a healthy skepticism. Remember who they work for, OWCP, not you personally. Number two, and this is crucial, control the flow of information. When you're talking to the nurse, especially about your medical condition, your symptoms, what you can or can't do, less is often more. Keep your answers factual, concise, brief. If they start asking really detailed medical questions, you can always politely refer them to your physician. For example, if the nurse says, "Hey, don't you think you could probably try light duty next week?"
Yeah, that sounds like a common push.
Right. A great response is simply, "I'll be discussing my readiness for work with my doctor at our next appointment." See? Cooperative but defers the decision.
Perfect. Deflects without being obstructive. I like it.
Exactly. Number 3, set boundaries on meetings, especially doctor's appointments. Remember your right to privacy during the exam. If you don't want the nurse there for the whole thing, say so politely. That strategy we mentioned, allowing them in just for the final few minutes, that's a solid approach. You can frame it positively. "I prefer to speak to the doctor one-on-one first, but I'm happy for you to come in at the end so we can all be on the same page about the plan." 4, document everything. I can't stress this enough. Get a notebook, use a notes app, whatever works. Log every interaction, dates, times, who you spoke to, a summary of what was said, save emails, save letters. This documentation is your lifeline if disputes come up later. It's your evidence. 5, be wary of overly friendly inquiries. Avoid the temptation to overshare personal details about your life, your finances, your family vacation plans. Keep it professional. Remember, seemingly innocent tidbits can end up in a report, maybe taken out of context. Keep conversations focused squarely on your injury and recovery. 6, use a support person if you need to. If you feel intimidated or just want a witness, consider having someone you trust with you. A family member, maybe a union rep if you have one. For phone calls, put the call on speakerphone with your support person listening in. That's perfectly acceptable. 7, stick to your treatment plan diligently. Go to all your therapy appointments. Take your prescribed medications. Follow the work restrictions your doctor gives you. If you do choose to decline a part of the recommended treatment, make sure your doctor clearly documents your reasons why in your medical record.
Okay, and what about that return to work pressure? It seems inevitable.
It usually is. So strategy 8, anticipate the pressure on return to work. As you start to improve, expect the nurse to talk more and more about getting back to work. Have a planned, positive, but non-committal response ready, something that always defers the final decision to your doctor. And remember the timelines. If your agency offers you a specific job, you generally have 30 days to respond. Don't let the nurse pressure you into accepting or rejecting something on the spot. And finally, number 9, know when to get advocacy. Know when to ask for help. If a case manager is really crossing lines, if they're harassing you, if they're misrepresenting what your doctor said, if they're pushing you towards something that feels medically unsafe, don't just sit on it. Escalate. Contact your OWCP claims examiner immediately. Talk to your union rep, or consult with an attorney who specializes in federal workers' comp.
Right. So using these techniques, you can navigate that tightrope. You cooperate as required, but you don't give up control over your own medical care. You and your doctor stay in the driver's seat.
That's the goal, absolutely.
Now, it's not just the injured worker who feels this pressure. Treating physicians can definitely feel caught in the middle, too. So for the doctors and other healthcare providers listening, how can they best navigate these interactions with OWCP case managers? How do they maintain their medical integrity while still engaging with the system? That's a great question because doctors play such a critical role. First, providers should understand the nurse's role accurately. Recognize they aren't there to medically second-guess you, at least not officially. Their job is information flow and tracking progress. A lot of their questions are driven by OWCP's need for specific documentation. So providing really clear, objective medical findings and detailed work capacity statements using those official forms like the OWCP-5 that can actually prevent a lot of back and forth and misinterpretation. Second, and most importantly, keep medical judgment paramount. Always. Your treatment decisions must be based on your clinical judgment and your patient's best interests, period. Not on the case manager's preferences or their desired timeline. If the nurse suggests a treatment change or pushes for a quicker release to work and it doesn't align with your medical findings, stand firm and document why you're standing firm in the medical record. Remember, OWCP cannot override your documented medical opinion with just a nurse's opinion. So confidence in their own assessment, backed by clear documentation, is key for doctors.
Absolutely. Third, doctors should set professional boundaries. It's entirely appropriate to manage how and when the nurse communicates with your office. Maybe you prefer non-urgent questions submitted in writing. Maybe you designate a specific time for a brief call after appointments. You don't have to be available 24/7 for spontaneous calls. Fourth, protect patient confidentiality. Yes, the OWCP nurse is authorized to get relevant medical info for the claim, but it's still good practice to get the patient's verbal okay before discussing their condition in detail. And definitely avoid discussing unrelated health issues. Stick strictly to the accepted work-related injury. Fifth, sometimes you can use the nurse to your advantage. A skilled, cooperative case manager can actually help you. They can sometimes expedite approvals for necessary tests versus specialist referrals because they can communicate directly with the OWCP staff. So you could try to leverage them to cut through red tape like getting that faster pre-auth for an MRI we talked about. Sixth, don't feel pressured by those return-to-work questions. If, in your medical opinion, the patient is not ready to return, state that clearly with your medical justification. If the patient could do some type of work, but with limitations, articulate those restrictions with extreme specificity. Don't just say light duty. Say, no lifting over 10 pounds, max 3 times per hour, or no repetitive keyboarding for more than 20 minutes without a 5-minute break. You are the medical authority on work capacity.
That level of detail sounds crucial. Vague restrictions leave too much room for interpretation, I imagine.
Exactly. Vague restrictions invite pushback or misunderstanding. Which leads to number 7, arguably the most vital for providers. Document your rationale meticulously. Justify your treatment plan and the patient's disability status in the medical record. Write it down clearly. For example, patient remains totally disabled for all work at this time due to objectively measured specific finding. Shane G. Grade 2 ankle instability and persistent pain with weight bearing exceeding 5 minutes. Attempting return to work now carries significant risk of re-injury and setback. That kind of documentation preempts so much potential conflict with the case manager. And lastly, number 8. Maintain professional communication. Always. Keep all interactions professional, factual, objective. If a disagreement arises, respond calmly. Something like, my medical assessment, based on the clinical evidence presented today, indicates X. If OWCP has additional medical information you feel I should consider, please ensure it is forwarded to my office for review.
Right. Keep it clinical, keep it professional. So, in essence, healthcare providers need to firmly assert their role as the primary decision makers for patient care. The OWCP case manager is a facilitator. Use them for that, but don't let them dictate clinical practice.
That sums it up perfectly.
Okay, but what happens when things really go sideways? What if, despite trying all these strategies, a case manager clearly oversteps their bounds or acts in a way that seems contrary to the rules? You're not just stuck, right? There are ways to hold them accountable.
Definitely not stuck. There are specific mechanisms for accountability. Your first step should usually be to report the issues to the OWCP claims examiner, the CE. If a nurse is acting inappropriately, maybe being unprofessional, maybe misrepresenting information, maybe unduly pressuring your doctor, you need to notify the CE. Be factual. Provide specific details, dates, examples. The CE supervises the claim and has the authority to intervene. They can talk to the staff nurse who oversees the contractor, or even decide to assign a different nurse to your case. You can also go directly to that supervisor. Contact the district office, staff nurse, SN. Remember, each OWCP district has a staff nurse who directly supervises these contract field nurses. If you feel the field nurse assigned to you isn't doing their job properly or ethically, you can request to speak with the staff nurse to voice your concerns. They are part of the oversight structure.
And what about using your own support systems, like your employer or union?
Yes, absolutely. Use your agency or union channels. If you're a federal employee, especially if you're in a union, they often have reps who know the OWCP ropes. They can advise you on how to file a formal complaint or how best to communicate your concerns about a problematic nurse directly to OWCP management. Now, if the behavior is really egregious, we're talking things like suspecting fraud, like altering reports, or telling a doctor to do something clearly unethical that might warrant escalating further. You can consult the OWCP Ombudsman or even the Department of Labor's Office of Inspector General, OIG. Reporting potential fraud, waste, or abuse is a serious step, but it's there for serious situations.
Okay, OIG for the really serious stuff. Any other avenues?
Well, if you feel like you're hitting a brick wall with the standard OWCP channels, sometimes a congressional inquiry can shake things loose. Contacting your U.S. representative or senator's office. Their inquiry to OWCP often gets a prompt and high-level review. And never forget your legal appeal rights if benefits are affected. If something the case manager did or said contributes to OWCP making an adverse decision against you, like reducing or stopping your compensation, you can appeal that decision. And as part of your appeal, you can argue that the case manager's input was improper or inaccurate. Remember that ECP precedent. A nurse's assessment is not medical evidence and can't override a doctor's report on its own. It's also important to feel empowered to document and confront misconduct in the moment, if possible and safe to do so. If a case manager clearly violates a rule, like that example of an employing agency nurse showing up illegally at your doctor's appointment, you should object right then and there. Cite the rule if you know it, and then immediately report that incident in writing to the OWCP claims examiner. Sometimes letting the nurse know you know the rules is enough to correct their behavior. Finally, if the relationship is just completely broken, totally counterproductive, you can formally request removal of the nurse in writing. Write a formal letter to OWCP, address it to the claims examiner and maybe the district director. Clearly explain why the relationship is untenable and request the nurse be removed from your case. OWCP might assign someone different, or they might decide they can manage the case adequately without a field nurse at that point.
Wow, okay, so there are quite a few levers you can pull if things go wrong. It really comes back to that idea. Knowledge is power. Knowing the rules, knowing who to contact, being able to cite specifics, that make your complaints much harder for them to just brush aside.
Precisely. Documentation and knowing the procedures are key.
So, wrapping this all up, it really sounds like dealing with OWCP case managers requires this delicate dance, a mix of cooperation and assertiveness. You have to understand the system to navigate it effectively.
That's a good way to put it. For injured workers, the key takeaways are: get educated on the process, communicate carefully, strategically, concisely, keep medical control by always deferring medical decisions to your doctor, lean on support systems when you need them, and don't hesitate to formally report problems when they arise. Use those tools.
And for the healthcare providers listening, assert your medical authority. You're the clinical expert. Collaborate on the admin stuff, sure, but never let clinical decisions be driven by outside pressure. Set those clear communication protocols, protect your patient's confidentiality, and always prioritize their medical interests.
Exactly. The ultimate goal of the system should be ensuring that sound medical judgment and the patient's well-being are central. When an OWCP case manager performs their role properly, within the rules, they can be beneficial. They can help coordinate things. But everyone involved, the worker, the doctor, the nurse, OWCP needs to remember and respect the boundaries and limits of that role.
And by knowing your rights, by asserting them appropriately, by reporting issues when necessary, you're not just helping yourself, you're contributing to the oversight and maybe even the improvement of the whole system. So here's a final thought to leave you with. If understanding these dynamics, these unspoken roles and incentive can empower you in a system as complex as federal workers' comp, where else in your life might a similar understanding be useful?
Yeah, think about other situations, other bureaucracies, maybe negotiations, interactions, where there are different roles and motivations at play. How could you apply these same principles: strategic cooperation, understanding the other side's goals, and setting clear, assertive boundaries to navigate those situations more effectively, turning potential friction into clarity and control?